Welcome to Ask Qendo, the official podcast of Qendo Australia, hosted by me, Jess Taylor, CEO. Through honest conversations with experts, advocates and changemakers, we myth-bust misinformation, break stigma and answer real questions about endometriosis, adenomyosis, pelvic pain, and we crack open Pandora's box. Welcome to our very first episode. This is our foundation episode where we're going to break down the basics of endometriosis, adenomyosis, PCOS, and Pandora's box that we know when we start to look into these issues, it just cracks wide open. We're going to talk about pelvic pain, and really this series is designed to be approachable, inclusive, and empowering to anyone newly diagnosed, seeking answers, or wanting to better understand these conditions. They are complex. We wanted a longer form discussion about some of the issues that you've likely seen in the comments online, and it's important that we have an open chat about this. I am your host, Jess Taylor. I'm the CEO of Qendo, and I have a lived experience of endometriosis, adenomyosis, pelvic pain, and other things in my Pandora's box. I'm here to guide you through honest, unbiased, and stigma-free conversations. These are complex issues, like I've said, and it's important that we have clear and accessible and open conversations about it so that you can be better informed to start building your toolbox. I am here with Albert Jung, Dr Albert Jung, who is a practicing gynecologist and a dedicated medical educator. Albert has a unique ability to break down complex medical issues in a way that feels clearer and compassionate and understanding. And in a complex space like this, it's important to have time to understand your options. We're going to launch this podcast with Albert to, again, break down from a gynae's perspective and also an advanced laparoscopic surgeon's perspective around surgery, to snip or not to snip. And no, I'm not talking about a vasectomy, and really understand a role of surgery, the role of medication, what's going on in our body, and what are these nasty lesions that can cause quite a bit of havoc doing to our body and our life. Thank you for being here, Albert. It's awesome to chat with you.
Thank you so much for having me, Jess. Happy to be here.
What does a day in your life usually look like?
A day in my life depends on the day, but I might get out for a quick ride in the morning.
What do you ride?
I road cycle. So quick little bike ride, maybe a trip up Mount Cootha, some lunch boxes, and then ward round, maybe some operating and some consulting.
Yes.
That's an ideal day.
You're a dad of 3 kids.
I am, yes.
A partner.
Yes.
Someone who's also in the medical space.
Yes.
So your life must be pretty busy.
It's busy, but we are just riding it. We're enjoying it and trying to take nothing for granted.
Yeah, for sure. So we've known each other for some time, and you have really grown in the space of learning about endo and doing lots of different surgical approaches and medical approaches. I want to talk with you about endometriosis first of all. What is this condition?
Yeah, so if we take a big step back, endometriosis is the endometrial-like tissue that should be inside the uterus, the endometrial lining, but it's not the same. That's growing outside of that uterus, yeah? Classically, it causes 2 main symptoms of pain and infertility, but pain can then be broken down into period pain, bladder dysfunction, bowel dysfunction, and painful sex. Yeah, in a nutshell.
So we also hear symptoms like brain fog and skin conditions and issues, and we're now moving away from endometriosis being a reproductive or a pelvic related issue. Where in your career have you seen endo be presented? Where other parts of the body have you seen it pop up?
So firsthand, I've seen it, of course, in the pelvis, on the bowel, on the diaphragm. Those are the most common places that I would see it, on the appendix. But absolutely, we've read about cases that have gone beyond the abdominal and pelvic cavity there, whether that is endometriosis on the knee. Yeah.
On the knee.
On the knee, yeah. And all the way up to the back of the eyeball.
The back of the eyeball?
Yes, absolutely.
So I have endometriosis in my pouch of ductless and also in my tonsils. So I was bleeding cyclically through my mouth.
Yeah.
But I've never heard of it on the back of the eyeball.
Yeah.
So why and how on earth do these lesions get there?
The short answer is we don't understand that completely. Yeah, we talk about lots of different theories, and there have been theories whether we are talking about retrograde menstruation theories. So we're talking about where every time you have a period, that blood, that menstrual blood that should flow out through the cervix, out through the vagina, onto a tampon or a pad or cup or whatever you're using, but sometimes will flow retrograde backwards through the tubes into the abdominal cavity. Now, this is a theory that has been around for a long period of time, and it has ebbed and flowed in terms of popularity. And I would say that it's coming back a little bit. It is not a perfect theory by any means. We know that if you were to put in a laparoscope in a woman who is menstruating, that over 90% of the time you will find some menstrual blood in their cavity. We know endometriosis rates are increasing and are high, but it's not that high. So it's not simply a matter of, hey, menstrual fluid causing endometriosis, but what makes those cells within the menstrual blood a little bit more resilient and more sticky and able to attach to the peritoneum? Those are the type of answers that we don't have. I think that theory explains a lot of the endometriosis that occurs inside our abdominal or pelvic cavity, but that theory does not generally explain endometriosis that are outside of the pelvic cavity. So above the diaphragm, for example. So the diaphragm separates our thoracic cavity from our abdominal cavity. So when you're having endometriosis up there, that's not going to explain, that theory is not going to explain that kind of disease. So again, lots of different theories, but one of the theories might be that when girls or those assigned female at birth are developing in their mother's womb, that there's these tiny little cells that should only go inside to the uterus, but somehow get misplaced and go elsewhere. And that would potentially explain those really weird cases of endometriosis in the tonsils. Yeah.
Well, it was so confronting as a 17-year-old, just waking up with blood all over
I'm sure it was. Oh, gosh.
It was back then. I wasn't even asked about my period pain, let alone bleeding through my mouth.
Yes.
And I cannot tell you how many scopes I had to work that out. I was having tonsillitis every 2 weeks, right? So there was some sort of inflammation going on there.
Yep.
But it just wasn't really looked at or discussed. And it was, years later when they went back and got all my samples and my tissue, they were able to slice it up and test for this, that we were able to look for it. So obviously had a tonsillectomy, but still we could remove that part, right? We don't remove other parts of organs in our bodies.
Correct.
Unless absolutely
correct,
drastically needed. Okay. So we know that there is some early documented cases of endometriosis. We're going a bit off script here, but from your archives of, experience and knowledge, can you tell a little bit about where endometriosis has been first found or diagnosed? Was it the French?
Ooh, you're really putting me on the spot.
I know.
With that one. I'm not sure if where the first documented cases of endometriosis were. I'm sure if we went back to some really old, even in the Chinese culture, for example, I'm sure there would be documented evidence and we would be able to look back and say, hey, those symptoms sound awfully like endometriosis. As you say, we just didn't know that.
We just didn't know that.
Yeah.
I remember one of the World Endo Society, I think he was the president at the time, talking about that the French used to use leeches and they put them in the body of women and they would then try and remove the lesions from that. And that practice was quite common until they lost a leech. And there's been quite an enormous amount of trial and error in this space, which can be really traumatic for some people too. But this is medicine, right? And it's a really unknown area.
You're right. That is almost the definition of medicine, and that's almost the definition of science.
Okay.
Yeah, where we try something, we learn from it, and we try again. Yeah, I like to use the terms trial and retrial rather than trial and error. Yeah, but that is exactly what. And I kind of cringe to think about what we'll think of what we are doing now in 50 years, in 100 years. They used to do what for endometriosis? Kind of thing. But yes, we might be in the same boat.
We might be a part of history.
Yeah, absolutely.
Well, I remember over 8 years ago, the common messaging was go and get go and get surgery, go and get surgery. Now, we are such a compliant, community where we're also pretty desperate to get help. So of course we went out and did the right thing because that's what the messaging was. And because everyone did that, we have data now, don't we, to learn about it's probably not always the best case or the best thing for people. Can you help us unpack that a little?
Yeah. Again, it's one of those things that ebbs and flows. Yeah. I think we went through a little period of, yes, everybody should have surgery to, nobody should have surgery. We shouldn't ever do surgery. And I think, as often the case, the answer is somewhere in the middle, and it's nuanced, and it's not a one size fits all for everyone. I will acknowledge my bias here that I do think that surgery absolutely plays an important role
for sure
in management of endometriosis, but it is not the one and only thing. And if anybody suggests that surgery is going to cure all of your endometriosis and all of your symptoms of endometriosis, then please get a second opinion. It has a place and it has a role, and it then depends on everything from your age to what your current fertility plans or desires are, the number of surgeries you've had. All of those things will factor into whether this is correct decision for you or might have something that's better for you.
You touched on the number of surgeries that maybe people have had, and I've had several, and one of those we know people who have had up to 20 surgeries. What's your take on repeat surgeries?
I think this is again a space that we're learning. We now have a better appreciation and understanding that more surgery can actually be quite bad for us. Yeah. More surgeries can increase our risk of adhesions and scar formation and nerve irritation. And every subsequent surgery becomes more and more complex. So certainly gone are the days of, hey, you've had a surgery, let's plan for another surgery in 12 months' time. That's a big no-no. Yeah. But again, that's not to say that there is no role for repeat surgery. And sometimes that's necessary. So for example, if you do have another big 4 or 5 centimeter endometrioma.
What's an endometrioma?
An endometrioma is endometriosis on your ovary is generally what we're referring to. An endometrioma, however, can refer to big clumps or nodules of endometriosis technically anywhere.
Are they called chocolate cysts?
We also call them chocolate cysts. Yeah. And again, most commonly we'll refer to endometriomas on the ovaries. Yeah. But that's something that we'll say, hey, even if you've had surgery 18, 24 months ago, we probably need to go and sort that out. Yeah.
There's such a diversity in presentation. So someone might have surgery once and done by a really good, well-trained surgeon who knows their stuff and be set for life, right? They can manage well with all of the other things in their toolbox. And other people have, and it doesn't matter the number of symptoms that people are living with, right? We know that the amount of disease in the body doesn't equate to the amount of symptoms someone's living with. So what are your thoughts on this complexity? Do we have different types of endo lesions? Are they all the same? Help us understand a little bit more.
Again, big area that we're researching into and getting a better idea of. We used to just say, yes, all endometrial-like tissue that's outside of the body, that's endometriosis, and we've just lumped them all into the same category. We have a better understanding that superficial endometriosis is probably different to deeply infiltrating disease. Yeah, deeply infiltrating disease that's about 5 millimeters or greater in depth. Yeah, and those are yet again different from your ovarian endometriomas and how they impact us from a quality of life, from a pain point of view, but also how they impact us from a fertility point of view is probably going to be different. Yeah.
And would you, so the recurrence of that might be that someone has a recurring type of lesion, whereas someone might not have that, would you say?
I think yes. Again, the things that we don't understand, what genetic predispositions that we have to more superficial disease or more deeply infiltrating disease. So absolutely, recurrence of disease is another whole area that we go, hey, what's going to happen there? What's going to happen in 5 years' time? Yeah. There is some interesting older studies that have looked at disease that just magically seems to go away. Yeah.
Oh, wow. Gosh, I wish we had.
Yeah.
I'll sign up for that one, please.
But that predominantly seems to be in the superficial groups rather than our deeply infiltrating endometriosis, our big endometriomas. Yeah. So again, I think there is something at a whether it be a biological, genetic, hormonal level that's different between those types of endometriosis that we just quite haven't fully grasped yet.
And this adds to the complexity. And this is why every single person needs to be looked at as that person, as that whole body, not just, different parts of their anatomy, right?
Absolutely. So we absolutely need to remember that this is a person. Yeah. Endometriosis is a subjective disease. Yeah. We do not need to, and we shouldn't get into the pitfalls of, hey, there's endo there, and therefore we must cut that endometriosis out.
Why?
Yeah. Again, because of the issues of, hey, what does this mean for more surgery? Where is it sitting? What are the implications of cutting that disease out? Are you going to have a worse quality of life if I take a segment of your bowel out than you're currently having? So it's not just a matter of there's, this caveman sort of approach of, there's disease I must cut out. And that's the nuance and the difficult conversations to have.
Particularly if patient, I've been one of them where I think, I have these symptoms of really rearing their head again. I think I need to have surgery. You must see that in your rooms all the time. And it's really difficult to then process when the treating, the doctor says, I don't think we should do that. How do you support people and maybe even educate people through that thought process? Can you break down, how do you think about that?
Yeah, it's often quite a difficult discussion to have. Yeah,
because we're coming in with expectations.
Absolutely,
because that's what we've known to do.
Absolutely,
yeah,
and it's absolutely a nuanced discussion to have.
Yeah.
One of the first things I would remind my patients is that a recurrence of pain doesn't always equal a recurrence of endometriosis. Remember, pain is complex. Pain is, again, when we look back at what we thought about pain, we used to think, hey, there's a stimulus, there's a signal, and there's a perception, and there's a pain, and there's all. And we know that it is much, much, much more complex than that. Yeah. So we know, for example, how tired you are, how much sleep you're getting, how well hydrated you are, whether you're having issues at work and partner. All of those things, for example, will factor into our perception, our feelings of pain. Yeah. So simply having a recurrence of some of those symptoms doesn't always equal a recurrence of endometriosis. Yeah.
This is why we need to look at the whole person then.
Correct.
Okay.
Yeah. Yeah. And that's where good imaging comes really handy.
Tell us about that. What do you mean by good imaging?
Again, this is an area where we have grown tremendously over the last several years. I think our first line of good imaging should be a good transvaginal ultrasound scan.
Okay. Can you tell us though, I'm going to we're going a bit off script here, team. But what if they're 16?
Yeah, absolutely.
Have a trans.
And you are absolutely right. And this is the nuance to medicine.
Okay.
Yeah. And I think we've kind of forgot to mention that this is general advice. Yeah. This is
definitely
absolutely individual. And you need to talk and you need to raise those concerns. If you are 16 and you go, hey, I've never been sexually active, I do not feel comfortable. You need to vocalize that.
Or even 25.
Absolutely.
There's different cultures that we have.
And if that's the case, then we need to look at something else.
Yeah.
And to answer that question specifically, we're probably looking at an MRI at that stage.
Okay.
Yeah. But a transvaginal ultrasound scan generally is cheap. There's very little risk to the patient. There's no radiation. If we get a good quality scan, we can get good quality information. Again, not necessarily to go, this is what that ultrasound says, and therefore I'm making my whole decision based on that ultrasound report. That is going to be a piece of the puzzle that we are going to put together to look at the big picture.
I heard from a really wonderful ultrasonographer, I think I've got that name right,
well done.
That we can rule endo in, but it's not to rule endo out.
Correct. We are, again, this has come along dramatically over the last few years. There is lots of research that's going in Australia, in Canada, and lots
really
of
cool people and
really
so clever.
Incredibly bright people.
Yeah.
Incredibly bright people.
Yeah.
And I think I would agree with that statement that when we have endometriosis, we are much better at ruling that in on an ultrasound scan. Yeah, if we can see it on an ultrasound scan, I'm going to be sure that you've got endometriosis. Yeah. But we are still at that phase where that superficial disease might not be picked up on on ultrasound scan, and we might miss some of that still. Yeah. Ultrasound scans are very, very, very operator dependent, meaning
very much
how you hold that ultrasound probe, at what angle, all of those things will impact on how the quality of that scan. So there are some departments, all over the world that will have higher pickup rates of superficial endometriosis, and some places that will have lower. Yeah.
And I just want to say that for many years we have said, again, this is what we knew, that an ultrasound cannot pick up endo or the lesions. And what we need to acknowledge now is that we have new technology, we have new training abilities, and we have an increase in time and funding with Medicare to be able to do those scans well.
Absolutely.
And there's a really growing group of incredible sonographers who are really trying to understand how they get good imaging for the team to make that diagnosis. So it's not just your Joe Blow down the road. It's a group that have done that training who know, and you can always reach out to us if you do need some pointers in who to go and talk to.
I think you've just highlighted, a segment of endometriosis with ultrasound scan that applies to the whole picture, which again is, it's not just about the machines, it's not just about who's scanning, and it's not just about the time and the funding. It's about all of those things coming together and marrying up so that we can provide the best service. Absolutely.
And that adds to the complexity,
Absolutely.
right? Yeah.
Absolutely.
So you've talked about these words like superficial, deep infiltrating. What do you mean? Can you explain to someone who has no idea what that is?
When we're talking about superficial endometriosis, we are talking about disease that is affecting the peritoneal lining, the innermost lining of our abdominal cavity or pelvic cavity. Yeah. Again, we can usually pick up superficial disease and pick up that lining, that peritoneum, and we can separate for it from all the underlying organs below. Deeply infiltrating disease refers to disease that is 5 millimeters or greater in depth.
Is it growing into the muscle or an organ?
It can be growing into a muscle or an organ, or it can just be thickening that peritoneum onto the uterosacral ligaments, which is a ligament, and in various areas, without necessarily going into a different organ, but absolutely still able to irritate nerves and peritoneum and cause more inflammation. Yeah.
When we have a good scan, when you as a surgeon have a good scan, what does that do in terms of helping to map out a surgery?
Yeah. It gives me a very good idea in terms of preoperative planning.
What does that mean?
What that means is I want to go into surgery with, and I want to start my surgery with the least number of surprises as much as possible. Yeah. Going in and finding something that I expected is totally different to going in and finding something that I was not expecting at all. So I want to try and while appreciating that ultrasound scan and MRIs and all the best history taking is only going to take us so far, I want to try and minimize those things as much as possible. So for example, if an ultrasound scan can tell me, hey, it's suspicious for bowel involvement, it's suspicious for bladder involvement, then I can put my colorectal colleague or my urology colleagues, whether that be on standby or I put them on as a joint case. If we are, depending on, again, the nuance of what we're finding on imaging, we can say, hey, you know what? Not only am I going to put them on standby, you're going to go see my colorectal colleague before we even go into surgery. They're going to talk to you about the pros and cons of bowel surgery, and we're going to make a decision here as to whether we are going to do that or not before we even go in and confirm that. And if we go in and find that actually this disease was nowhere near as bad as we thought it was, that's a great bonus.
Great outcome.
Yeah, absolutely. Yeah.
Yeah. Okay.
Stand down. Yeah.
Yeah.
Tell the colorectals that they can go home or go have their cup of tea. Yeah.
Yeah.
But that's the type of stuff that I think preoperative imaging is really, really useful for.
Yeah. And it sounds like as patients, we're trying to assemble our team, but we have to really, and the role of that is to best prepare our surgical team and for you to prepare your team in that operating theatre and those that need to be in the wings. And so great. But what do you do if it's in the thoracic cavity? Who do you get in? So we understand the bladder, we understand the bowel, but who on earth do you bring in if it's in your lungs?
So the thoracic cavity up there is not an area that we gynecologists feel very comfortable.
We don't want a gynae up there.
No, you don't. You don't. And so there's a couple of ways that you can go. We can either get a hepatobiliary surgeon involved or a cardiothoracic surgeon involved.
Okay.
And again, it kind of depends on the disease. Is this disease that is on the diaphragm, or is this disease that has penetrated through the diaphragm into the pleural cavity? Yeah. And what's it impacting? Is it in the lungs? And you might be better with a cardiothoracic surgeon in those cases.
If someone does, I do see this comment quite a bit, and people say it's rare, but I disagree with that because there's so many comments and people's lived experiences, and it may not be rare or uncommon in the books, but I just don't think we haven't researched it enough right yet. But from your experience, what would some of the symptoms be if someone did think about they may have endo outside their pelvic cavity and more in the thoracic cavity? What do they present with?
If we're talking about thoracic cavity or diaphragmatic disease, we might get symptoms like chest pain, might get symptoms like pain with deep breaths or exertion. If we are into the the pleural cavity, we might, very similar to you, we might get hemoptysis. So we might get blood with coughing. Yeah. And particularly if those things are happening on a cyclical basis, right? Yeah.
I wondered that.
It's my period and I'm having these symptoms and they're lining up, and we start connecting those dots together. Absolutely.
Yeah. Start tracking people, because that's so much data. What if someone does come to you with that kind of data, how does that help in your puzzle piece that you're trying to put together?
Yeah. I think tracking is very important. There's so many apps, the Qendo app, those are really, really fantastic for us to look at things at a retrospective, to go, because it's easy to get caught up in the busyness of our lives and go, when was my period again? And how many, and endometriosis is sometimes very easy. It's a disease that's easy for us to gaslight ourselves with, to go, I had a terrible period, but I'm okay now.
Forget about it.
Yeah. Was that period really as bad as I thought it was? Maybe it wasn't that bad.
And we'll probably come to see you on a good day, right?
You often do. Right? But I think tracking helps us to keep a record, to go, hey, I wasn't making that up. It was really terrible. And look, it is happening
again and
regularly.
And sometimes it gets worse, right? That spiral, that pattern continues. Yeah. Okay. We need to talk about the evil cousin of endometriosis that we know as adenomyosis. It is difficult to live with, and I'm sure even difficult to manage, more so than endo. What do you think?
Yeah, I would agree with that. So adenomyosis is like endometriosis. It's the endometrial-like tissue that should be inside the uterine cavity, but if it's in the muscle layer of the uterus, that's what we're calling adenomyosis, right? It is the evil twin sister, cousin, whatever you want to call it. And a lot of the symptoms do overlap. Period, heavy, painful periods, and infertility or subfertility.
And that sciatic nerve pain that shoots down the legs.
Can be as well.
So, or restless legs we hear as well, that lower back pain.
Yeah. And there is, again, some changing of thoughts as to what is the relationship between endometriosis and adenomyosis. Yeah. Are these two separate conditions? Or actually, are they all under the same umbrella? Are they all ectopic placements, so abnormal placements of endometrial tissue, which it is? Yeah. I think endometriosis and adenomyosis, to our understanding, and again, this will change with time, there's lots of overlaps, but perhaps how they come about might be a little bit different as well. So our adenomyosis patients often have had some sort of trauma, whether that be uterine curettings or a myomectomy or a cesarean section, previous birth. Those seem to be higher associations with adenomyosis than they do with endometriosis. And again, I think that's a watch this space. Maybe in 5-10 years time, I'll say, hey, you know what? That's the same disease. Just as though we have a different name, like an endometrioma for when it's on the ovaries, we're calling it adenomyosis when it's in the uterus, but actually it's all the same stuff. Maybe not. You're right. Adenomyosis is a little bit trickier to manage, particularly surgery-wise, because I can't cut into the uterus as I can strip the peritoneum to cut that adenomyosis out. It often has very poor borders and has significantly higher consequence and sequelae of cutting into the uterus than peritoneum.
Yeah, ouch.
So surgically, it's much more trickier.
Yeah. And it's an area that's delicate, right? That is constantly changing. And there's so many considerations. So what could you do to help manage adenomyosis?
Adenomyosis really, if the first question I ask with regards to adenomyosis would be, what are our fertility plans right now?
Okay.
Because if there are no fertility plans, then I think hormonal suppression, medical management is the way to go. Yeah.
Why? Why do we want to do that?
Yeah, because we know that hormonal suppression will reduce our inflammation, will reduce our cycles. Yeah.
Okay.
But we can't do that if fertility is our main desire. Yeah, and that's a problem. And so yes, then we need to look at how can we reduce the inflammation, and do we use something for a short period of time to try and reduce things, or do we just go straight to some fertility treatment? Yeah.
I've heard some other talks on the description of a bleed, so a period, being a mini inflammatory response, which then we want to try and switch off as many inflammatory responses as possible, is that why gynaes suggest pills and, hormonal suppression?
Yes, I would agree with that concept of every time you're having a period, you're having a little bit of a flare and an inflammatory spike there. And I think that mirrors some of the data that exists out there that our increasing rates of endometriosis mirror our reducing fertility rates. Yeah.
Yeah. Because
when we're pregnant, we have a 9-month period where we're not having these periods and we're in a relative hypoestrogenic state. Add on to that our breastfeeding. If we're breastfeeding for 6 months or 12 months and we're not getting periods, so we have seen these patterns, not causal relationships, but we have seen these patterns to suggest that, hey, with our reducing rates of fertility, our increasing rates of our endometriosis rates are increasing. Similarly, with our delayed time to first pregnancy or first-time moms, that also seems to mirror our increasing rates of endometriosis. So I think there is something there as well. Absolutely. Absolutely.
We went out to the community and asked them some questions. So they've put in a question for you, Albert, and we're going to listen to it now.
All right.
Hey guys, what's one thing you wish more people understood about living with endometriosis or chronic pelvic pain?
I think I touched on this a little bit earlier. I would say that, hey, that there is no one solution. There is no one solution for everyone, and there is no one solution for you. And what I mean by that is surgery is going to play a role. Hormonal suppression might play a role for you. Simple analgesia might play a role, but also a dietitian, pelvic floor physio, a psychologist, a sex therapist. They're all going to have a little role to improve your overall quality of life. And individually, they might not seem like they're doing great things, but together collectively, they are. To put in a little cycling reference, we talk about incremental gains that these world-class athletes trying to save 20, 40, 50 grams on a little seat post or something like that. But individually, not very important, but collectively can make a big difference.
So we have a lot of questions from the community that say, well, what does this physio or this psychologist have to do with these lesions in my body? What do you say as a gynae?
Okay. Should we talk about physio specifically then? Let's do it. So, the first part I want to say there is endometriosis is not, again, we want to really move away from lesion disease. Yeah. This is a whole body disease. This is an inflammatory process. This is a nerve irritation. This is a whole body disease. So with that, one of the things that physios can, not the only thing, but one of the things that pelvic floor physios can help us with is our natural response to pain is to contract our muscles, right? If I poke someone with a pen, they're going to contract their bicep muscles and they're going to pull their hand away. our natural response to pelvic pain is to contract our pelvic floor muscles. So whether that pain is coming from endometriosis or adenomyosis or otherwise, we're going to contract. Unfortunately, we need to contract and we need to relax our pelvic floor muscles when we want to particularly pee, poo, and have sex. And if you can't relax and squeeze appropriately when you need to, then you're going to have dysfunction in peeing, pooing, and sex, just like the main symptoms of endometriosis that we talked about.
And just walking and sitting and all that.
Absolutely.
And I think if you're listening to this, just check in with that pelvis of yours. I was conditioned to do Kegels at every red light, which I think for someone with an overactive pelvis is not great.
No.
So just take a moment to check in with that pelvis of yours, as I'm doing now. And Albert, I encourage you to do the same because, men have pelvic floors.
Absolutely. Absolutely.
And that's also important to just, it will probably be held quite tight and just let that sit. And we're actually speaking with the really awesome Zara Howard at another episode called The Fanny Mechanics, where we're talking about our pelvis that deserves more than WD-40.
Oh, fantastic.
It's going to be so much fun. So we do have another question from the community, and this is one that we get asked a lot.
Hi there, I've just got a quick surgery question for you. Why is it that a hysterectomy won't cure endometriosis? Thanks.
That's a great question. We need to go back to what is endometriosis here. So remember, endometriosis by definition is endometrial-like tissue outside of the uterus. A hysterectomy is referring to the uterus. So if I take the uterus out, but if I was to leave all this disease on the peritoneum, over the bladder peritoneum, in the pouch of Douglas, then that's not going to help us.
Because they've set up camp, right? These lesions.
Correct.
And don't they create their almost own little ecosystem?
Yes. And in lab studies, they've shown that they can produce their own kind of estrogen levels there.
Wow.
Yeah. So whether they're kind of self-sufficient to grow on their own. But that's why a hysterectomy in it of itself is not treatment or a solution to endometriosis. A hysterectomy, if your family is complete, absolutely should be part of the discussion if we are going into surgery to cut out your endometriosis, though. Absolutely.
And even some younger people who are choosing not to have a family, we hear that hysterectomy, they are really interested as a part of that piece for them. But then we think about bone health and what is okay, hold the phone. What is a hysterectomy? I think we need to break that down because there's different types.
There are absolutely different types of hysterectomies and different routes of how we perform a hysterectomy. When we are talking about a hysterectomy, even if we say a total hysterectomy, what that's referring to, a total hysterectomy is referring to your uterus coming out and your cervix coming out. That's it. If we are talking about your tubes, we're talking about a salpingectomy. Yeah. And if we were talking about your ovaries, we're talking about an oophorectomy.
And you can have all of that done at the same time.
You can have all of that done at the same time. All of those things come out at the same time. So more commonly, we would do that in our women who are postmenopausal in their mid-50s and onwards, where we would quite routinely take out tubes and ovaries to minimize then their risk of ovarian cancer. We now know a lot of ovarian cancer starts in the tubes, about 30%. So we know just taking tubes out, for example, will reduce our risk of ovarian cancer.
And there is a growing body of evidence that shows the overlap of endo and a higher risk of ovarian cancer.
There is. And again, I would be very careful to make this distinction here that it's not endometriosis that's necessarily becoming cancer, but absolutely, particularly your endometriomas. So we talked about endometriosis on the ovaries in our postmenopausal women do have a higher association or maybe potentially a higher propensity for malignant transformation there. But as a big general statement, your endometriosis, we think it's the same pathways that have allowed endometriosis to grow elsewhere that's allowing ovarian cancer to grow. So not necessarily endometriosis becoming ovarian cancer, except in that small subset population.
Really good to define that because it can be really scary. And look, the media and the feeds are good at fear-mongering us. And it's important to, because it's complex, right? And the data is complex, so it's important to have those conversations.
Absolutely.
So hysterectomy, even if someone is young and they really don't want to have children, when could hysterectomy be possibly on the table for that group, and what do they need to think about?
Yeah. Again, it's a nuanced discussion there. Yeah. And a new consult for me takes a full hour,
Wow,
because
yeah.
we need to
Good.
talk about all of
Yeah.
those things, and we need to talk about and ask about the why and what does this mean for, as you mentioned, bone health, and
Yeah.
and what does this mean for libido and all those kind of things. As a big general statement, if we are doing a hysterectomy at an early age, we're going to keep those ovaries in, which means that hormonally we should really be the same. Yeah. But to get to that, it really depends on what are our symptoms and what are we expecting to get out of this hysterectomy. Yeah. The two main indications that we do a hysterectomy is for heavy bleeding and pain.
What does heavy bleeding equate? Like, what my heavy bleeding might be different to the next person's heavy bleeding. So what's your definition of heavy bleeding?
You're absolutely right. Just like how your pain is going to be different to everybody else's pain. But again, heavy bleeding where you are passing heavy clots, certainly if you are having significant drops in hemoglobin, shortness of breath, that's easy. That's a lot of bleeding. But passing large clots, and again, it comes back down to, hey, how much is this impacting on your quality of life? Yeah. That's the definition of heavy menstrual bleeding to me.
I love that, because we've often heard, if you're soaking through X amount of pads, or because but what is your normal?
Yeah.
And what is it impacting your life? I think that's a really easy one to start with.
Yeah. Yeah.
And we, could have normalized that, but do we actually want to live like that too, right? Do we want to wear the pants that we want to?
That's right.
We want to not have to worry about getting up and just having flooded the seat.
Yeah.
That is impacting someone's quality of life if they're having to think about that.
Absolutely.
Yeah.
So when we then talk about setting realistic expectations, what are we expecting from a hysterectomy? Yeah. If those are the two main indications that we are getting, from a bleeding point of view, if I was to do a hysterectomy, I can almost guarantee that your bleeding is going to stop. Not that it should get lighter or less, it should stop. Yeah.
So keeping the ovaries.
Keeping the ovaries.
Keeping the fallopian tube.
No, taking the tubes out.
Taking the tubes out.
The tubes will have no function. The main function of the tubes are to allow sperm and egg to meet. And if you don't have a uterus, well, they have no function.
Do you still ovulate if you keep your ovaries?
Yes, strictly speaking, you ovulate, but we have to keep in mind that your eggs are tiny and they'll just get reabsorbed in the body.
Into the body.
Yeah.
Okay, so stupid questions now. There are no
Never a
stupid
stupid
questions here.
question.
I know,
Yes.
but I really want, this is such an area that people don't talk about. So keeping the ovaries, you have the vaginal canal,
Yes.
the cervix is gone.
Yes.
What do you do? Do you sew it up? You sew it up.
I do suture it up. So
Right.
effectively what I do is I detach the cervix and the uterus from the vagina in this relatively thin avascular plane called the vaginocervical junction there.
Oh, yeah.
And what that does is, and I then bring those two edges of the vagina and I do suture it up.
Wow.
Yeah.
Does that must impact the sensitivity there?
Yes. But the vast majority of women will say, no, their sexual life actually improves because we've managed to reduce their bleeding and pain. And we know, again, that sex is so complex. Men and women are just wired differently.
We are so
right?
wired differently.
Men will have sex anytime. Yeah.
Yes.
Whether they are stressed or they're happy or sad, they will use sex as a form of stress relief.
Yes.
Yeah? But women,
regulation.
yes, women are totally different.
Yeah.
As a general statement, women need to be relatively well fed, relatively well slept. Yeah. Feel safe.
Yes,
Yeah.
definitely.
With no pain.
Yeah.
Yeah. And that will change how they feel about sex.
Yeah, and our wonderful queer community who then just defeats all odds. And,
Yes.
there where we're speaking with the incredible Hunter later on in the series, where we're getting into the experience of someone who is trans and transitioning and queer too. So, listen out for that episode where we unpack that there. Okay, so you don't bleed after the hysterectomy?
So you should not bleed after a hysterectomy. Yeah. Of course, you can then have recurrence of endometriosis in the vault, but as a big general statement, you should not bleed. So I'm quite confident to say, hey, after you have a hysterectomy, you should not bleed. I can't make such a strong promise about pain. As we talked about and we've mentioned multiple times so far, pain is so complex. Yeah. So yes, doing a hysterectomy absolutely should improve your pain, but I would not ever, ever, ever say, hey, this is going to solve all of your pain. And so that's the type of discussion that you need to have. Why are we doing this? Are we doing this for pain or are we doing this for bleeding? Because if it's predominantly for pain, we might come out of this and go, hey, I'm a little bit better, but I'm not all that better, which of course then has long-term implications as well. Yeah, not only on fertility, but prolapse risk. There is a higher risk of prolapse.
What's a prolapse?
So a prolapse, when in this context, we're talking about a prolapse of either the bladder or the rectum into the vaginal space.
So it's like falling into the canal.
Correct.
And just to note, we're not the vulva is the out. We're just going to do some basic anatomy here. Tell us if we have Virginia, the pelvis in front of us.
Yes.
Can you talk us through for people who are watching what the basic anatomy is? Because I think we probably need to start there too.
Yeah, this is great. So
pull apart my pelvis.
Pull apart your pelvis. Which camera am I looking at?
We've got ligaments going on. We've got.
This is great. So naturally, we do have our bladder that sits right in front of our uterus, and then our rectum that sits right behind it. Yeah. And understandably, yes, if you have irritation or if you have inflammation that's happening at your bladder, because of its close proximity, you are going to get those bladder symptoms, right? When we're talking about, and maybe we just can't quite get in there, but again, if we're talking about prolapse, what we're talking about is that bladder and rectum falling into the vagina. And then we can also talk about vault prolapse, where what I have sutured together, that then falls through as well. Yeah. So strictly speaking, yes, a hysterectomy increases our risk of prolapse.
You've changed the anatomy and the structures, right?
Absolutely.
Yeah.
But again, it's too short-sighted to look at that only. We need to then look at, hey, are we overweight? Yeah. Are we doing our pelvic floor physio? Yeah. Are we a smoker? Do we have a chronic cough? Are we constipated? All the things that increase our intra-abdominal pressure on a regular basis is also going to increase our risk of prolapse there. Yeah.
And we're not talking about BMI here, right? Because BMI, people and Eating Disorders Queensland do a really great job of this, where the BMI might look high, but you look at the person and they're actually quite stocky, right? So their height and their muscle tone is different. And are you talking about overweight? Because that can also be a triggering part for some people. What are you trying? It sounds like there's a risk to the treatment if there is additional Jubilee bits hanging around.
So to be clear, when we're talking about prolapse, we're ultimately talking about intra-abdominal pressure.
Okay.
If you're increasing your intra-abdominal pressure, that's going to increase your risk of prolapse.
Because it's heavier to carry?
Correct.
Okay.
Correct.
Okay.
Yeah. BMI, I absolutely agree with BMI. Yeah, BMI is not the measure that we should be, or we're looking at to go, hey, you are healthy or you are not healthy.
Throw that in the bin.
Absolutely not. There is still a role for BMI because it's a quick and easy way of doing it to make associations, particularly at the far end of that spectrum of BMI. So we're not talking about, your BMI is at 25, 27, 28 kind of thing. We're talking about if you are in the far outer either side, yes, those things will apply more to you. But yeah, I agree. BMI in itself is a terrible one-stop measure. It's not designed for a one-stop measure of overall.
It's not designed for women or people who assign female at birth bodies these days either. Yeah, for sure. You've mentioned briefly about these quick fixes or lack of in this really complex space. What would you give in terms of some supportive ideas if someone is saying, I can fix this or I can, sort that for you? What would you say to people to just question that?
Yeah, I would question that. And I think it's okay for clinicians or health professionals to say, hey, I can help you. Yeah, we can do this journey together. That's different.
To fixing.
That is totally different to, I will fix this for you and I'm going to take you from, you're not broken, but broken to that. Those are totally different things, things. And I would be very, very, very careful about somebody who speaks that way. Yeah. It probably sound like a broken record, but I really want to highlight that there is no one fix. Yeah. And some things will work better for you than others. Yeah. And you might get, let's say, 80% relief from this one thing, whereas somebody only gets 40, and that's great. Yeah. But to have hopes on one thing fixing everything, it's unrealistic.
We throw that in the bin too, don't we?
Borderline dangerous.
Yeah, borderline. Yes, we've heard that. tell me, what is a laparoscopy?
Sure. A laparoscopy is also known as keyhole surgery. Mm-hmm. It's a procedure where I make small little incisions. And there's lots of different ways to do this, but most classically for me is a 1 centimeter cut at the umbilicus, at the belly button, and 3 5-millimeter cuts. And at that belly button, I put in a long telescopic camera. That image then goes up onto a big screen, and I operate visually, kind of separation between where my hands are and where I'm looking, to cut out endometriosis.
But you don't have your hands inside the abdominal cavity.
I do not have my
these
hands.
scope things?
Yeah, so I have a long camera, and I have these long instruments. I have scissors that are on a stick that's, let's say, 35, 40 centimeters long. Yeah. So it allows me to reach into the pelvis without putting my hand in there. It's kind of like operating with really long chopsticks.
What a visual. So is it invasive?
It absolutely can be invasive. And we need to remember that, one, not all laparoscopies are the same. Yeah. Your first laparoscopy is going to be completely different to somebody who's having a fourth laparoscopy with altered anatomy for bowel involvement and bladder involvement and a hysterectomy. Those two things are completely going to be different. Excuse me. But yes, it is absolutely invasive. Yeah. It is absolutely, again, cutting into your abdominal cavity, and it is a general anesthetic. Yeah. And again, medicine has come a long way, and we do really, really well. And anesthetics, as a big general statement, is safe. Yeah, but it doesn't mean no risk. Low risk never means no risk. Yeah.
Why do we get shoulder tip pain after those surgery? Gosh, they hurt.
Yeah. So shoulder tip pain most comes from gas that's irritating our diaphragm. Yeah. And that's called referred pain.
But hold on a minute.
Yes.
Why have you got gas in there too?
So with the laparoscopy, what I've done is I've actually filled your abdomen with gas.
Oh, you've like blown it up like a balloon.
Like a balloon.
Oh, okay.
Correct. And I've done that to, one, give me space in there for us to work with, and to separate the organs that need to be separated. So for example, you talked about the pouch of Douglas. It really allows me access to the pouch of Douglas with gas and a manipulator to allow me to get into that pelvic space and to cut out endometriosis if I need to.
So I've got a visual now. So if you're in there and you've blown it up, would you be able to see things that are stuck together then?
Absolutely.
Yeah.
So that gives us a much better idea of, hey, that is a true adhesion, or that is a true stuckage, not really a word, or whether that was a false finding on an ultrasound scan or an MRI, because MRIs often can find it difficult to say, hey, yes, ovaries and bowels and uterus are sitting on top of each other, but are they actually stuck together, or are they're just where they are
together.
hanging out? Exactly.
Yeah, because all of our anatomy is also not the same. That's right.
Correct.
So we're going to touch on the last condition that we're going to talk about, which is PCOS, which is just such another complex space. What is PCOS? I've heard there's 4 different types of PCOS. Can you unpack that a little?
So sorry, Jess. Can I go back to the diaphragm and the gas there for a second? So that
finish that.
No. So the gas is effectively irritating that diaphragm, and our body's interpreting that as shoulder tip pain. And that's a great example of what we call referred pain. Yeah. And that's also a great example of why our pain sometimes feels different inside. We don't have the same nerve endings and nerve fibers on the inside of our body as we do on the outside of our body. See, on the outside, if I, again, I don't like poking patients with pens, I promise, but if I was to poke you with a pen again, you can tell me exactly where I poked you, how hard, how long, whether it was the ballpoint end or the dull end. You can tell me those things, but we don't have those same nerve fibers on the inside. So our body can't tell us those things. And that's a great example of that referred pain. Mm-hmm. So sometimes when we have, hey, I predominantly have right-sided pain, we go in and we find, ooh, look at that. Our endometriosis is on the left side. Yeah.
Because it's referring over.
Correct. Yeah. And those signals are kind of getting a little bit mixed up. A little bit mixed up.
So you haven't, King hit us on the shoulder when we
No, absolutely. I haven't done anything to your shoulder.
nothing.
Yeah.
But it's that trapped
Correct.
gas that needs to be relieved.
Yeah. And the more we get up and move around, the more we pass wind and open our bowels, the quicker that gas will
Moves
dissipate
around.
out.
Yeah. Okay. PCOS. It's a really complex one. I hear there's 4 different types. What is PCOS? What does that mean? Can you unpack that?
Yeah. So PCOS stands for polycystic ovarian syndrome. This is, again, a big evolving space. We might come to a point in a couple of years where we don't even call it polycystic ovarian syndrome anymore. There's a big push to consider a name change for that, mostly because I think the name PCOS gives an overemphasis on the polycystic nature of those ovaries. And we know that for a lot of women, that's part of normal, particularly in our young women and our young girls. This is, yes, it absolutely has implications into pelvic pain and irregular periods and that gynae space with fertility, but this is really a metabolic condition. Yeah, this is a issue of insulin resistance, and it has implications for long-term issues of type 2 diabetes and obstructive sleep apnea, and yes, endometrial hyperplasia. But this is more endocrine than true gynecology, as we would say.
So who would you see to support you with the PCOS?
Yeah. And this is where it overlaps.
Yeah.
If you find a gynecologist who is happy to manage your PCOS, then absolutely. Again, because there are big overlaps between the symptoms, the disease, and the symptoms. And a lot of these symptoms can be gynecologically focused. Yeah. And it also then depends on where are you looking to go? Are we looking to fall pregnant? Yeah. Then you absolutely want to see a fertility specialist. But more and more, we are again seeing endocrinologists. Yeah. So physicians to manage PCOS. Yeah. It's not a one size fits all.
None of this is a one size, which is frustrating too as a patient, because we often come and see you guys when we've had enough.
Yeah, absolutely.
And we need help. And we really, again, as you've said, we gaslight ourselves into this is normal, this is normal, this is normal. And then we just reach this point of, I am not okay. I'm not functioning.
I think we're getting so much better at this. Yeah. But that has been the problem of, hey, who do we go to when we have our first period at 13 or 14? Who do we go to? We go to our mums. Yeah. We go, hey, mom, I've had a terrible period. I'm bleeding. And what does sometimes mom say? That's okay. That's what the tailors do. Yeah. You've got terrible periods. I had terrible periods. Your grandmother had terrible periods. Yeah. Your aunts have terrible periods. That's what we do. Yeah. But we now have a better appreciation, understanding that, hey, it's not that that's normal. It's that probably everybody in that family had endometriosis.
Normalized it.
Yeah. It normalized their pathology.
It's funny because when I was diagnosed, and it was actually my dad who was a really big advocate, because he was out there buying, I'm the eldest of 4, 3 girls and a boy. He was out there buying the pads and the tampons, and he noticed this increase. He's this ochre guy from, the bush. And so he didn't really care. It's a means to an end, right? That's how he approaches it. And he was noticing these increase in needs, the amount he was buying. And he said to my mum at one stage, you got to check in with these.
It was a financial observation with
it. And I think when you're buying food for that many kids, it's a big trolley. And, these pads were taking up quite a bit of that real estate in the trolley. He was very much practical, as we love dads are. And I remember after my work in this endo space, being diagnosed myself, it was probably 7 or so years later that my mum come to me and said, everything you've been speaking about, I think I've lived with that too.
Yeah.
And she went on to be diagnosed with endo and adeno, and had treatment, and she's well, but she actually had not she had normalized it, right?
And we absolutely shouldn't give mums too hard of a time, because we didn't.
That's what they knew.
Exactly. They didn't have access to this. Yeah. They didn't have access to great quality ultrasound scans and laparoscopies, and unfortunately, they probably were also gaslit by their GPs and their medical community
Yeah.
sometimes.
Yeah, for sure. What happens after surgery? What do you want people to really, they have surgery or they are, whether it then be diagnosed or you don't find anything, that's also a tricky one. What do you encourage people to look and do post your appointment or surgery?
I might touch on what do we do if we find nothing?
Yeah. It's a big one.
That's a big one. That's a hard one. Yeah. And I will tell my patients that this is the best outcome. Yeah. This is the best outcome. Endometriosis, it can be a chronic debilitating disease. And if we don't have it, then that's fantastic. Yeah. Humbly, I would say that you've had surgery with a competent surgeon.
We'll hope so. Yes.
And
that's not always the case. But
And what that then means is we can stop barking up the endometriosis tree. We can stop incorrectly looking at endometriosis as the cause of all your pain. And we can, yes, it's frustrating, but we can take a big step back and say, hey, what else is going on? Is it actually okay if it's not endo? Is it actually our bladder? Is it actually our bowels? Yeah. Knowing that there's huge overlaps between IBS and Crohn's and endometriosis. Is that what we need to look at? Do we need to look at a pelvic floor physio? It really allows us to sort of reset things a little bit and reapproach things with a different light. So I totally acknowledge that is a point of frustration, but that is good news. Even though it doesn't seem like it's good news at the time, it is absolutely good news. Yeah.
And you can still be validated in your symptoms, in your experience, without having that.
Correct. No endo on laparoscopy does not mean that this is all in your head or you were crazy. No, not at all. It just means that endometriosis was not the cause of your pain. And we can then move on to finding what else is the cause of your pain.
Or maybe wasn't present, and we know that people sometimes a bit later on, they start to grow.
Yes, that's another great little point. And that then brings us back to one of the things of, hey, the younger you are, the more we should really be trying to avoid that first laparoscopy. And I'm talking about your 14, 16-year-olds kind of thing. There is some evidence that going in too early will have false negative rates, that we go, oh yeah, this is a perfectly pristine pelvis. And it was just all microscopic and we've missed that. Yeah. So
it usually looks a bit like jam, right? In the pelvis.
It can look, and this is one of the tricky parts of endometriosis, it can have multiple phenotypic appearances. Yeah.
It can look different.
It can absolutely look differently. So it can have different colors. You can have a clear sort of vesicular sort of
like
appearance.
A blister on your hand.
Yes, like a blister on your hand. Yeah. To all the way to like very clear black nodules. Yeah. Sometimes it's red, sometimes it's pink, and sometimes it's got more like a bluish tinge.
Wow.
Yeah. And it is where the more you look at it, it is pattern recognition to a degree.
Which is why you need to see someone who has done and taken the time and financially invested in additional training, in additional knowledge, understanding, skill building to look for these.
Absolutely.
And this is where we have absolutely the role for the general gynecologist, absolutely. And we also have a very special role for endometriosis interested, because we don't have a specialist, subspecialty in this space. I've been talking to Ranscog about this for a couple of years, but we don't have one. So we're conscious of not being an endo specialist, but a special interest of endo. Would you agree?
I would agree with that. And I don't think volume is everything. Yeah, but volume is a very important part of that.
Volume of surgery.
Volume of surgery, volume of what you do day in and day out. Yeah. If you are delivering 20, 30 babies a month, you are going to be better than the person who's delivering 1 or 2 babies a month. Yeah. And that's no different to surgery. It is a physical thing. It is a muscle memory thing. The more you do of something, the better you are going to be at it.
Yeah.
Yeah.
Thank you so much for unpacking all of that with us. It was a big one, but I really hope we have smashed through some myths and some big things that we've needed to unpack for a really long time. And if you would like to share this episode with people who you may have needed to share information about your own experience, or just better understand the options that people have, or also better understand why your health team may have said this, that, or the other, follow along this series with us. I promise you, there are moments of tears, there are moments of inappropriate conversations that we're going to destigmatize. And we're excited to bring some really interesting people to the camera with you and give the conversation that these conditions so deserve. Next up, we have Kate Fisher, who's a sexologist, and we're going to talk about pain in the sheets and between the pain meds, around sex, around intercourse, around penetration. I'm really excited. This episode, we're going to also spotlight the support line. If you would like to talk through or debrief anything that you have heard, call us. We are here. There is an incredible team who is eager and available with lived experience to talk with you and discuss your experience and what's going on for you. I'd like to thank the sponsors of this podcast, Gideon Richter, Greats Media, Foxwood Clothing, and Premium Pilates.